of the NCSI webinar is non-convulsive status epilepticus, how to recognize it, and later on how to do the management. So we have with us Dr. Sarika Juneja, who is the principal consultant from Max Super Specialty Hospital, Saket, New Delhi. It is it's an honor to have her with us to present this seminar on this topic. This topic is very important for us as neurophysicians who take care of these sick status patients, where recognition of these non-convulsive seizures when it is delayed obviously leads to a lot of poor outcomes. Now, I quickly hand over the stage to Dr. Sarika. Dr. Sarika, you can go ahead and take forward this seminar.
Thank you, Dr. Bharath. Good evening, everyone. Today I'll be presenting on the topic non-convulsive status epilepticus. It is a Pandora's box, but I'll be briefly covering all its aspects with special emphasis on the recognition and management. Non-convulsive status epilepticus, it is a common complication of acute neurological brain injury, and it is associated with worse neurological outcome, including later epilepsy, functional status, and cognition. Diagnosing non-convulsive status epilepticus demands a high degree of clinical suspicion, and for that reason, it likely remains under-recognized. Electroencephalography is fundamental in the diagnosis of non-convulsive status epilepticus. Seizure burden reduction while avoiding iatrogenicity is the mainstay of treatment. So, non-convulsive status epilepticus, it poses a multi-dimensional challenge for the neurologist as well as the neurointensivist. The challenge being the diagnosis, the optimal therapy, and the difficult prognosis. Diagnosis, it is challenged by the limited agreement on the diagnostic criteria, and there are no randomized control studies for the treatment protocol. Different subtypes of non-convulsive status epilepticus, they have different outcomes, so it is very difficult to explain the prognosis. By the end of this class, we should be able to define non-convulsive status epilepticus, the epidemiology, the pathogenesis, the subtypes of non-convulsive status epilepticus, and the diagnostic criteria and pharmacological management, also the prognosis. So coming to the definition given by the International League Against Epilepsy, status epilepticus is a condition resulting either from the failure of the mechanisms responsible for seizure termination or from the initiation of mechanisms which led to abnormally prolonged seizures. It is a condition that can have long-term consequences, including neuronal death, neuronal injury, and alterations of neuronal networks depending on the type and duration of seizures. Actually, this definition defines two time points, T1 and T2. So T1, when it is convulsive status epilepticus, is 5 minutes, which means that if a seizure lasts more than 5 minutes, it has high chances of not terminating on its own. And T2 defines the time after which long-term consequences can happen. That is 30 minutes in convulsive status epilepticus, but in non-convulsive status epilepticus, it is the T1 is 10 minutes and the T2 is around 60 minutes. Non-convulsive status epilepticus is defined as status epilepticus without a prominent motor component. Non-convulsive status epilepticus may have zero motor component, or it may correlate with subtle movements like subtle facial twitching. And non-convulsive status epilepticus is diagnosed on the basis of either electrographic or electroclinical seizures. Coming to the epidemiology, non-convulsive status epilepticus represents 47% of all cases of status epilepticus in the intensive care unit. Out of these, 12 to 33% of patients in cardiac arrest, they develop non-convulsive status epilepticus, and in cases of traumatic brain injury, 8 to 35% of patients can have non-convulsive status epilepticus. Those with pre-existing seizure disorders, they have lower mortality, around 3%, rather than those in which the non-convulsive status epilepticus is associated with any acute medical condition. Non-convulsive status epilepticus, it most severely impacts the elderly, and it may be due to the complex interplay of etiology, the comorbid conditions they have, the complex treatments they are going on, and the side effects and the drug interaction of various anti-epileptic drugs. Non-convulsive status epilepticus in the elderly represents 16% of the causes of confusion without specific etiology and 8% of unexplained coma causes. The mortality rate in elderly approaches 36%. Coming to the pathophysiology, absence status epilepticus, it's an inhibitory state which occurs via the thalamocortical networks, via the GABAergic transmission in the nucleus reticularis. Focal status epilepticus is rather an excitatory state. And here, the hippocampal, limbic, and neocortical networks are activated via the excitotoxic mediators like the NMDA and the glutamate receptors. Coming to the causes. So, the causes can be known or cryptogenic. In the known causes, the common ones are the cerebrovascular injuries like the ischemic or the hemorrhagic strokes, the subarachnoid hemorrhage, the cerebral venous sinus thrombosis, fat embolism. Then post-cardiac arrest patients, they usually have this non-convulsive status epilepticus because of the hypoxia or anoxia to the brain. Electrolyte disturbances like hypocalcemia or hyponatremia and hypomagnesemia can lead to non-convulsive status epilepticus. The foremost important cause is the anti-seizure medication in patients with known epilepsy who have poor compliance, or if they have change in anti-epileptic drug levels, maybe because of addition of any enzyme inducer like carbamazepine, or in cases of genetic epilepsy, if inappropriate anti-seizure medications are used, then the patients can develop seizures. Alcohol withdrawal or benzodiazepine withdrawal can lead to non-convulsive status epilepticus in the elderly. Metabolic causes like porphyria and hyperammonemia can lead to non-convulsive status epilepticus. Head injury is an important cause of non-convulsive status. CNS infections like meningitis and encephalitis. Then various endocrinology states like hypo or hyperglycemia and hypo or hyperthyroidism. There are many autoimmune and paraneoplastic causes. Then there are dementias like Alzheimer's disease, in which non-convulsive status epilepticus is seen. Parkinsonism rather gives protection against this sort of status epilepticus. It is mainly seen in Alzheimer's disease. Then there are many electroclinical syndromes like Angelman syndrome and ring chromosome 20 syndrome, in which non-convulsive status epilepticus can be a presentation. So coming to the causes, coming to the symptoms of non-convulsive status epilepticus, in 82% of the patients, confusion is seen in 82% of the patients. And speech disturbances like aphasia, mutism, echolalia, stuttering, it is seen in 15%. Myoclonus is seen in 13%. Altered behavior is seen in 11% of the patient. 7% patients may present with catatonia, and there may be psychiatric symptoms like anxiety, agitation, aggression, and hallucinations. Any new and rapid emergence of these clinical features in association with known risk factors for non-convulsive status epilepticus should lead the clinician to exclude non-convulsive status epilepticus using an EEG. Coming to the classification. The classification of the non-convulsive status epilepticus is based on the semiology. So non-convulsive status epilepticus can be divided into non-convulsive status epilepticus with comma, without comma. It can be focal with impaired consciousness, without impaired consciousness, and it can be generalized, which is mostly known as the absence status epilepticus. I'll be discussing these subtypes in brief. So coming to the clinical subtypes, focal status epilepticus without impairment of consciousness, patient may present with positive or negative symptomatology with preserved awareness. Patient can present with hemiparesis, ictal alien hand syndrome, and hemispatial neglect. Sensory, autonomic, visual, olfactory, gustatory, emotional, psychic, and auditory symptoms may be present. Underlying focal epilepsy is commonly seen. Then focal epilepticus with impairment of consciousness, symptoms may vary by involved area of cortex. The temporal lobe may be involved. In that, when temporal lobe is involved, fluctuating consciousness, fear, irritability, aggression, automatisms may be seen. In frontal lobe type 1, unilateral form with affective disinhibition or indifference and emotional lability. Frontal lobe type 2 is more severe. It is a bilateral form with confusion and severe altered mental status. Generalized non-convulsive status epilepticus, also known as the absence status epilepticus, it is most commonly seen in teenagers with idiopathic generalized epilepsy. Sudden onset of cessation of activity, Blank stare and unresponsiveness are usually seen. Patient may speak repeated words. There may be screaming, crying, hallucinations, or abnormal movements, including rhythmic blinking, eyelid, perioral, or limb myoclonias. De novo absence status of late onset. It is a peculiar absence seen in patients over 50 years of age, which is usually seen after sudden benzodiazepine withdrawal. Associated precipitating factors may be the excessive use of psychotropic drugs, history of chronic alcoholism, or metabolic disorders like hypocalcemia and hyponatremia. The clinical presentation represents that of absent status of subjects with idiopathic epilepsy, confusion, impaired lucidity, and generalized spike-wave discharges may be seen on the EEG. Non-convulsive status epilepticus with coma is usually seen after convulsive status, or it may be seen in encephalopathies. No convulsive activity is usually noticed, but myoclonus or nystagmus may be present. So, coming to the evaluation part, which is very important. So, when to suspect non-convulsive status epilepticus? If there is any fluctuation or unexplained alteration in the behavior or mental status, patients who have generalized tonic-clonic seizures and are in prolonged post-ictal period, patients who have unexplained stupor or confusion in the elderly, stroke patients who look clinically worse than the expected deficit caused by the stroke, or if there is any paradoxical response in any ICU patient whose alertness improves after receiving a benzodiazepine or any anti-seizure medication. Coming to the history and examination, we should inquire about the patient's baseline neurological function. Any abrupt change in the mental status, like any new onset psychosis, must be inquired. There must be a proper history about any recent change in the medication or poor compliance of the anti-seizure medication in patients who are known case of epilepsy. There should be history of recent trauma or even remote trauma, infection, or recent illness should be inquired. Remote or chronic risk factors like traumatic brain injury, stroke, meningitis, encephalitis, brain tumor, neurosurgery, Alzheimer's disease, and dementia should be acquired. There should be inquiry of any prior episodes of any stereotypic events. We have to check for fever, head trauma, tongue bite or laceration, posterior shoulder dislocation, any urinary incontinence, any abnormal eye movements like nystagmus or hippus. It is said that abnormal eye movements have 86% specificity for non-convulsive status epilepticus. If there is any sustained head and eye deviation, there is any hemispatial neglect, there is any focal myoclonus of the face or limbs, or there are automatisms like repeated stereotypic purposeless movements like lip smacking, orofacial twitching, arm and hand movements such as pecking or fidgeting. Coming to the laboratory studies, blood glucose should be done to exclude hypoglycemia. Electrolytes and ABJ must be done to rule out any metabolic disorder like hypoxia or hyponatremia, hypocalcemia, hypomagnesemia. CBC, RFT, LFT should be done to rule out any organ system dysfunction. Urine analysis and urine toxicology screen can be done to rule out any intoxication. The serum anti-seizure medication levels where possible should be done. Pregnancy test in women of childbearing age and the pyridoxine levels. A diagnostic lumbar puncture and CSF examination should be done in patients whom we are suspecting to have meningitis or encephalitis. Cultures and serology can be sent in cases of sepsis. Neuroimaging. So, neuroimaging with CT or MRI is usually done in any patient with altered sensorium to identify any common causes of non-convulsive status epilepticus, stroke, tumor, traumatic brain injury, infection, or inflammation. If the CT is normal, then definitely we have to go ahead with the EEG. So during seizures, there is usually increased glucose and oxygen demand of the epileptogenic cortex, leading to ictal hypoperfusion, which leads to vasogenic and cytotoxic edema. These changes are reflected in different neuroimaging modalities, which can be useful either to diagnose status epilepticus or to localize the area of the brain which is involved by the ictal activity where EEG findings are equivocal, or if in case it is not available. Perfusion studies like CT perfusion and MRI perfusion, they can localize ictal hypoperfusion and they are usually done in emergency. The more elaborate PET is usually not done, and in PET, hypometabolism, it indicates stroke, while hypermetabolism is usually evident in non-convulsive status epilepticus. MRI abnormalities which are seen in non-convulsive status epilepticus. Diffusion weighting imaging in MRI shows hyperintensity, while there are corresponding low values in the ADC, which means that cytotoxic edema is present because of the status. The areas involved are usually the cortical regions which are involved in the status epilepticus and the hippocampus, thalamus, putamen, and nucleus caudate. Diffusion changes which do not correspond with the vascular distribution obviously support the diagnosis of status epilepticus rather than any acute ischemic stroke. Changes of status are usually transient and they disappear within few days. In case the patient has cortical laminar necrosis, mesial temporal sclerosis, and focal vein atrophy, they depict permanent structural damage with consequent permanent functional damage and chronic epilepsy development. So this is an MRI of a female patient with known epilepsy and sepsis in which the anti-seizure medication was stopped because of the sepsis. The DWI hyperintensities can be seen in the right hemisphere, in the thalamus, hippocampus, head of nucleus caudatus, and parts of the occipital lobe with marked swelling of the cortex, depicting cytotoxic edema. EEG is fundamental to the diagnosis of non-convulsive status epilepticus. Usually, a full EEG array based on the international 1020 system remains the technical standard. But nowadays, 7-lead or 8-lead subhairline arrays have also been studied. One study by Westover depicted that reduced EEG with 10 electrodes in the circumferential configuration preserved the key features of traditional EEG system. Rapid response EEG is in, but the benefits are that the results can be acquired in less than half an hour, but the specificity and sensitivity is definitely reduced. Can I interrupt for a moment? Actually, the animation are not playing.
Ma'am, you can try once again.
None of the animations in the past slides also played.
Okay.
Can I share the screen?
Yeah, you share the screen, madam. Yes.
Because none of the animation is working, and in the further slides, then when I am depicting the EEGs, it will become a problem.
Okay, ma'am. You can stop sharing and again share the screen. Once again, you
Okay.
can try that.
Okay. Okay. Okay.
Dr. Sarika, are you there?
Yeah, yeah. I am in the screen.
Yeah, yes, ma'am. Dr. Sarika, are you having any
Yes,
difficulty?
yes, 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 yes. Just.
You can share the entire screen, ma'am. That would be ideal.
Yeah, yeah. I am just. Dr. Bharath, are my slides visible?
Not yet, ma'am. Yeah. Okay.
Are my slides visible?
I'm not able to see your slides yet. Are you able to share your screen, ma'am? Dr. Sarika,
Yes.
are you able to hear me?
Yes, yes, I can hear you.
Yeah. Maybe by the time Sheen cares, we can take up few questions which are there in the chat. Is that okay?
I actually I'm just. Can you see the screen once? Can you let me know whether you are able to see the screen now?
No, ma'am, I'm not. I'm still not able to see your screen.
Just give me 2 minutes for just sharing the screen, and then maybe I'll be able to take the questions as well.
Okay.
Am I visible now?
You are visible, ma'am. You are visible and audible, but your
No,
screen
no.
we are not able to see.
Is my screen, sorry, is my screen visible?
No, ma'am. We are not able to. I'm not able to see your screen. What does it say, ma'am, when
Yes, yes. Now,
you
now,
are?
now I think you should be able to see.
Yeah, your
Dr.
screen we are
Bharat,
able to see, ma'am. Yeah, we are able to
now
see your
you're able to
screen.
see the screen?
Yes, yes.
I'm so sorry for this move up.
No problem, ma'am. You can go back
Okay.
to the slide you are in.
Yes, yes. Uh, are my slides still visible?
Your slides are visible, ma'am.
Okay.
We are
Should
at
I
your
start?
third slide. Yeah, you can make it full screen and then you can start, ma'am.
Yeah, I'm already full screen.
Maybe, yeah. There's a little lag, ma'am. It's okay.
Is it okay now?
Yeah, it's okay, ma'am. You can go ahead.
Okay. So electroencephalography, it is the fundamental of the diagnosis of non-convulsive status epilepticus. So full EEG array, as I mentioned, the 10 to 20 system,
Madam,
sorry, still remains the
the slide has not become full screen. You can try once again.
okay.
Madam, you can continue. Go ahead, ma'am.
Now is it? Can you see my slides?
Your slides are visible, ma'am.
Okay. Can I go ahead?
Yeah, go ahead, ma'am, please.
Okay. So the diagnosis of non-convulsive status epilepticus, it requires electroencephalography, and it may be diagnosed on the basis of either electrographic or electroclinical scissors. So coming to the electrographic and electroclinical scissors, an electrographic scissor is an epileptiform discharge averaging more than 2.5 Hz for more than 10 seconds. And any pattern with definite evolution and lasting more than 10 seconds also falls into the category, criteria of electrographic scissor. What is an electroclinical scissor? Electroclinical scissor is any EEG pattern with either a definite clinical correlate time locked to the pattern of any duration, like facial twitching or hand movement or nystagmus, or if there is EEG and clinical improvement with parental anti-seizure medication. The electrographic seizure becomes the electrographic status epilepticus when the electrographic seizure continues for more than 10 minutes, or there is a total duration of more than 20% of any 60-minute period of recording. In this case, we can see that there are 25 epileptic discharges in 10 seconds. So this falls into the category of electrographic seizure. And secondly, any pattern which has a definite evolution in morphology, frequency, or there is any incrementing onset or decrementing termination, also which has a typical spatio-temporal evolution, also falls in the category of electrographic scissor. Hello. Okay, now
Madam, your
coming.
slides are not moving, ma'am. We are at 31 on the screen. Yeah, now we are at 35. You go ahead, ma'am. Yeah.
Uh, Actually, okay. Are they moving now, Dr. Bharath?
No, ma'am, they are not moving. I think your full screen is not getting depicted here.
Yeah.
It's
Yeah.
your
So
before.
what should I do?
It's
Should I
okay.
shift back to?
Yeah, you run with the same file, ma'am. Previously, what you had,
But
like
then
without
the
going full screen,
videos,
then it is working.
then none of the videos will play. Okay,
Hmm.
let's see then.
Okay. Yeah, this is fine, ma'am. We are able to see the slide.
But this is not full screen. Should I continue with this then?
Yeah, this you continue with this, ma'am.
Okay, fine. So coming to the EEG, we'll be now if you see the frontopolar and the frontal, are they moving now, Dr. Bharath?
Uh, Madam, we are able to see your slide number 36. Yeah, now it is 37. Now it moved.
Okay. So if we see these 3 pages of the EEG and we examine the right side, the frontopolar and the frontal electrodes, we'll see that there is a definite evolving scissor. There is definite evolution seen in the frequency as well as the morphology. And if we see, then we can see that now this has evolved in the location also. Now few epileptic discharges we can see on the left hemisphere also. I'm so sorry, with this the animations are not playing.
It's
So
okay. We
coming
are
to
able to
the
see your slides.
okay.
Okay.
So coming to the electroclinical scissor, any EEG pattern which has a definite clinical correlate time log to the pattern. It may be of any duration, or if there is EEG and clinical improvement with parental with administration of IV anti-seizure medication. So this is the EEG of an 89-year-old woman who was found confused with minor movements of the extremities and later of the face. If we see, then there are lateralized periodic discharges, and they are time logged with contralateral motor semiology. So this fulfills the criteria of electroclinical scissor. And if the scissor lasts for more than 10 minutes, then obviously it is electroclinical status epilepticus. Coming to the ictal interictal continuum. So this term is synonymous with possible electrographic scissor or possible electrographic status epilepticus. It is a purely electrographic term and it is not a diagnosis. There is a reasonable chance that it may contribute to impaired alertness, causing other clinical symptoms or contributing to neuronal injury. But surely we can't stamp it as scissor unless and until we do a diagnostic treatment trial with a parental anti-seizure medication and there is clinical as well as EEG improvement. The following patterns, they can be considered on the ictal interictal continuum. Any periodic discharge or spike and wave pattern that averages more than 1 Hz and less than 2.5 Hz over 10 seconds can fall in the ictal interictal continuum. Then there are two types of modifier, a plus modifier and fluctuation. The plus is an additional feature which renders the pattern more ictal appearing than the usual pattern which is without a plus. The modifier applies only to the periodic discharges and the rhythmic delta activity. Plus F means with superimposed fast activity, defined as theta or faster. Plus R means with superimposed rhythmic delta activity. Plus S means with associated sharp waves or spikes or sharply contoured waves. With fluctuation, which means that the changes in frequency, location, or morphology which don't qualify as evolving. Definite evolution cannot be seen, but there are more than or equal to 3 changes, not more than 1 minute apart in frequency, morphology, or location. So this is a periodic discharge this is a periodic discharge in which we can see superimposed fast theta activity. The other is a periodic discharge in which we can see rhythmic delta activity. And this periodic discharge has both fast as well as the rhythmic delta activity. Any periodic discharge or sharp wave pattern that averages more than 0.5 Hz and less than 1 Hz over 10 seconds and has a plus modifier or a fluctuation. So we can see the fluctuation of frequency in both the patterns. Then any lateralized rhythmic activity averaging more than 1 Hz for 10 seconds with a plus modifier or fluctuation. In this, In this rhythmic delta activity, we can see fast activity also is present. Then in this rhythmic delta activity, sharp waves are seen. And then in this rhythmic delta activity, both fluctuation as well as sharp waves are seen. Any lateralized rhythmic activity more than 1 hertz for more than 10 seconds with a plus modifier or fluctuation. In this graph, we can see fluctuation of frequency. Many EEG criteria have been given since 1996, but the one which is widely accepted is by Brzezinski, known as the Salzburg consensus criteria, which was given in 2013. So in this case, patients who are without known epileptic encephalopathy, if they have epileptiform discharges more than 2.5 hertz or epileptiform discharges less than 2.5 hertz, or there is rhythmic delta theta activity more than 0.5 hertz, and one of the following: either EEG and clinical improvement after intravenous anti-epileptic medication, or there is subtle clinical ictal phenomena during the EEG patterns mentioned above, or there is typical spatiotemporal evolution. All of this I have mentioned before. In patients with known epileptic encephalopathy, there may be increase in prominence or frequency of the features when compared to baseline EEG of the patient. And there is improvement of clinical and EEG features with intravenous anti-epileptic drugs. This depicts the same. If there are epileptic discharges and their frequency is more than 2.5 cycles per second, also if the frequency is less than 2.5 per seconds, but there is typical spatiotemporal evolution, or there is a subtle clinical ictal phenomena attached to it, or there is a definite clinical and EEG improvement with the intravenous AED, we can stamp it as non-convulsive status epilepticus. In case after a intravenous anti-epileptic medication, there is only EEG improvement without any clinical improvement, then we can call it as possible non-convulsive status epilepticus. This criteria was modified in 2015, and it included that if the clinical symptoms and signs raising the suspicion of non-convulsive status epilepticus, they should last for at least 10 minutes, and the EEG changes which fulfill the criteria should also be present in continuity for more than 10 seconds in a complete abnormal EEG recording. So now coming to the appropriate length of EEG monitoring. There we go for routine EEG or for continuous EEG. The routine EEG usually is done for only 20 minutes, but the continuous EEG is usually done for more than 24 hours. Many studies have been done, and continuous EEG has been found to be more sensitive than routine EEG. Continuous EEG monitoring should last for at least 24 hours, as most patients experience their first electrographic seizure within the first 24 hours of monitoring. And use of continuous EEG increases the detection of seizures and finally may lead to reduced mortality. And in a patients with ongoing non-convulsive status epilepticus, continuous EEG should at least be continued until the resolution of NCSE and throughout the titration and weaning of the continuous intravenous drugs. In a study by Struck AF et al. In 2017, a score was designed. The 2B score, which helped us in predicting the length of EEG monitoring necessary to identify subsequent seizures with accuracy after 1 hour of EEG monitoring. So here I have depicted the 2B score. The score has the following risk factors. If the epileptiform discharges are more than 2 hertz, one score is given to that. If they are if they are characteristic electrographic epileptiform discharges, the score is 1. If there are lateralized patterns like lateralized periodic discharges, lateralized rhythmic delta activity, or bilateral independent periodic discharges, the score is 1. Plus features, they are also given a score of 1. Any history of seizure, recent or remote, is given a score of 1. And 2 points are given for bilateral ictal rhythmic discharges, 2. 2 points are given for birds. They find that birds are highly epileptogenic. So if we see that the score is 0 at 60 minutes of continuous EEG recording, then the predicted risk of seizure is just 3.1%. And for seizure risk reduction to less than 5%, only 1 hour of the EEG monitoring can be done. And for a seizure risk reduction of less than 2%, 3.3 hours can be done. But if the score is equal to or more than 2, then the predicted risk score of seizure is more than 25%, and the EEG monitoring for a risk reduction, for a seizure risk reduction of 5% has to be done for 24 hours, and for seizure risk reduction less than 2%, it has to be done for more than 30 hours. But this study unfortunately excludes the cardiac arrest patients, so it is not valid in patients with cardiac arrest. Now coming to the treatment part, the first and foremost question is, how aggressively should we treat? So the rationale for aggressive treatment is that non-convulsive status epilepticus is superimposed on non-convulsive status epilepticus seen in patients with acute brain injury has been found to be injurious to the neurons. Studies in TBI depict that there are elevations in various markers of brain injury, like neuron-specific enolase, extracellular glutamate, and lactate to pyruvate ratio. Non-convulsive status epilepticus after TBI, ICH, and SCH may result in metabolic stress and raised ICP. So, non-convulsive status epilepticus after a convulsive event has consistently been associated with worse outcomes than convulsive status epilepticus, which doesn't have a subsequent non-convulsive status epilepticus. So, whether or not the rationale against the aggressive treatment is that there are certain morbid conditions in which there may be various associated EEG findings, but they may not benefit with the aggressive management. And the use of IV benzodiazepines in critically ill older patients especially has been associated with prolonged hospitalization and increased mortality. So there is a question mark on the safety of such aggressive treatments in such morbid patients. The primary aim should be first to do no harm. Coming to the pharmacological treatment, proper treatment algorithm for NCSE remains unclear as there is paucity of evidence and it is limited to mostly retrospective studies. The treatment has mostly been extrapolated from guidelines which recommended the treatment of generalized clonic seizure status epilepticus. Initial therapy for patients presenting with non-convulsive status epilepticus is definitely IV benzodiazepine plus a non-coma inducing IV antiseizure medication guided by continuous EEG. In patients with pre-existing epilepsy, optimization of the ongoing anti-seizure regimen has to be done. In non-convulsive status epilepticus still persists after the initial IV dose, then repeat doses without significant delay at a lower or same dose can be done. The drug pharmacokinetics is definitely altered in critically ill patients, but we need to know that the loading dose has not to be changed. Any liver or renal failure will only lead to changes in the maintenance dose. The loading dose makes the therapeutic level, so the loading dose has to be kept the same despite any organ dysfunction. And in depending on the subtype of non-convulsive status epilepticus, it is the coma-inducing anesthetic agents are avoided. But aggressive treatment is definitely required in few non-convulsive status epilepticus types, and it is coma-inducing anesthetic medications may be used in if the non-convulsive status epilepticus is the aftermath of convulsive status epilepticus, in patients with acute brain injury, and in the setting of cryptogenic new onset refractory status epilepticus NORS. This flowchart depicts the same. After using the tier 1 and the tier 2 drug, if there is still if the seizure burden is still high, or if there is coma stupor, but the non-convulsive status epilepticus is the result of generalized status epilepticus, then we have to shift quickly to these intravenous anesthetic drugs. Otherwise, if it is focal status epilepticus with impairment of consciousness, multiple anti-seizure medications can be tried, and even the enteral anti-seizure medications can be tried. Once the coma is instituted, after achieving burst separation for 12 to 24 hours, then it has to be tapered with continuous EEG monitoring. these are the doses of the drugs commonly used. These are the doses of the benzodiazepine. We commonly use lorazepam or midazolam in a setup. Then these are the non-sedating anti-seizure medication used. In our ICU, we are using Levipil and lecosamide in patients with non-convulsive status epilepticus. Then these are the oral non-sedating anti-seizure medications. Continuous infusion can be done with midazolam or propofol, pentobarbital, and ketamine. We usually use a combination of midazolam and propofol in our ICUs. Uh, Ketamine also has been studied a lot, and it is also being now used quite frequently. Um, the slide won't work. Dr. Bharath?
Yeah, yes, ma'am. Maybe you can tell us the content of the slide. Maybe that would be okay.
Okay. So I'll do that.
Ma'am, to make it full screen, no, what I've been told is if you stop sharing screen, share the
Yeah.
screen without the slide and later on open the slide in it.
Share the screen without the slide. Okay. Okay.
Yeah,
That I
share the
can do.
screen without this. Yeah, that you can do and then open the slide again and then make it full screen. Uh, can we take a question, ma'am, if it is okay by then?
Yes, yes. You can take a question. Anyway, the slides are going to end. There are just two, three slides which are
Correct, ma'am.
there.
That's good. Ma'am, till now it has been a great presentation with a lot of information for us. One of the questions in the chat is why seizure medication was stopped in patients of sepsis?
Oh, that were the MRI findings.
This is the question by Dr. Saurabh, maybe following that. Why seizure medication was stopped in patient of sepsis?
Actually, she came in sepsis, and there was a history of not taking the scissor medication. Probably she was sick for some time at home, so it was not stopped by us.
Okay,
And so she
that was an
presented.
accident.
So she presented. A scan was just done. So she was in altered sensorium at home for past 2 days, and a scan was done in the emergency only because they suspected a stroke.
Correct. Okay, ma'am. So it was an accidentally they had stopped it, not intentional,
Yeah,
right?
yeah, yeah. The
That-
patient had stopped.
Okay, okay. Then there's one question on can you put some light on how to get suspicious of non-convulsive status in patients who is intubated and drowsy or on sedation, like in patients who are not fully awake, like in the ICU, how do you suspect in such patients?
There can be subtle signs like there can be nystagmus or there can be facial twitching seen in such patients. I have noticed one patient who developed arrhythmia. He developed AF without any reason. So there can be many uh, autonomic symptoms and signs also. And this is it. And then
Yeah,
EEG
maybe.
is the main thing. We usually go for routine EEG for half an hour and then accordingly decide.
May agree, ma'am. So maybe when we give sedation vacation, that time also would be helpful for us, especially in sedated patients, to maybe suspect patients who have non-convulsive status.
If we are suspecting non-convulsive in a sedated patient, then definitely we give a break from sedation for some time.
Agree. Correct. Then there's a question
Can you
on how is the drug
Bharat,
management in
I'll just
non-convulsive
interrupt you for a
status?
moment. Can you see my slides now?
Uh, Maybe it's happening, ma'am. Right now, I'm still not able to see it. You share your screen, ma'am. Afterwards, you open your PPT in that.
Nee, I have done that.
We are still not able
But
to see your screen. Maybe it takes some time to once you share to come out like.
Bharat, can you see them now?
Not yet, ma'am. I think it takes a few minutes to come out, ma'am. Can we
Okay,
take another question by
then
that?
yes, yes, yes. Sure.
Uh, is the drug management in non-convulsive status different or same as status epilepticus in
Uh,
terms of choice of drugs and how you go
it
about in
would
the
be
approach?
it actually depends on the subtype. If it is
Okay,
absence, then obviously we are going with the non-sedative sedating medication. But if it is like the aftermath of convulsive status epilepticus, the management is more or less similar on the similar lines.
okay, okay. Then for viewers, whenever the radiological picture is not meeting a clinical picture, then that's when Dr. Saurabh suggests that we go for EEG and suspect non-convulsive status. Sir was just
Yes, yes,
putting for his thought
yes,
for
yes.
especially when patients on
Because
sedatives.
this is a normal scene in our ICU. If we see a patient with altered sensorium, then we get a CT done, and then if there is no change in the CT, then we order an EEG.
And other thing I wanted to ask you was regarding the use of how important it is to identify the cause for non-convulsive status, especially in the early phase by
Uh,
using
Actually, actually, the management and the prognosis depends on the cause, so it has to be identified at the earliest.
agreement. Ma'am, you have given such a detailed description of the EEG, especially how to differentiate electrographic and electroclinical seizures, the Salzburg consensus guidelines, and also how to gauge the risks. I wanted to ask you, like, most of our hospitals will not have a specialized EEG technician to use the full array or all the 32 channels. Is there any role for a lower number of electrodes can we put, or is there a role for BIS at bedside in these
Yes,
patients?
yes, they can be used, and when the scissor load is high, it will definitely be picked. So uh, people have started using it, and the studies I had gone through, they say that the in some cases the diagnosis of non convulsive status was made in half an hour, though with the routine or the continuous EEG, and even if a specialized technician is not available, then it may take more time and the management may be delayed, but the sensitivity and specificity is quite low. There may be chances of missing some cases.
Okay, okay. From your end, you can try again to share your slides if it is possible.
Bharat, I'm not able to. Can you see my slides now?
Yeah, it's coming up, ma'am. I'm able to see your slide like your regular page, not the full screen. We are able to see your slide, ma'am.
Bharat, can you see the slides now?
Uh, we are not seeing the full screen, ma'am. It is the regular version which we are seeing, the non-full screen version.
Okay, then there are just 3 to 4 slides remaining. I'll read them. I'll mention these.
Yeah, yeah. You can mention the salient map feature. Correct.
Okay. So, in a recent 5-year observational study by Orlandi, it was seen that no significant differences were seen when valproate and Levipil were used in patients with generalized convulsive status epilepticus, while in non-convulsive status epilepticus, valproate was found to be more effective. It was found to be effective in 86% of the trials, compared with Levipil being effective in only 62%. Then, in 1999, a study was done by David and Freeman, where it was seen that all the drugs like lorazepam, phenytoin, lorazepam, diazepam, and phenobarbital, they had equal response rates in patients with overt convulsive status epilepticus, but the response rates were consistently low in non-convulsive status epilepticus. The only randomized trial which has been done in pharmacotherapy of non-convulsive status epilepticus is the one comparing lacosamide with fosphenytoin. And in that, it was seen that lacosamide was non-inferior to fosphenytoin, and the treatment-related side effects were also not increased in cases where lacosamide was used. Many studies have been done on lacosamide. Lacosamide has been used in refractory non-convulsive status epilepticus, and it has been found to be a useful adjunct. One study was done by Chung in 2012. Then a recent study done in 2021 by Asia Pioneer, which compares Levipil and lacosamide in the treatment of non-convulsive status epilepticus, says that lacosamide was more effective than Levipil when it was given as the first-line medication. Then we come to treating the underlying cause. The underlying cause has to be
Ma'am,
treated.
sorry, ma'am,
Yes.
your slide is stuck at 72. Yeah, now it's
Okay.
at
Now
74.
can
You have to click on
okay.
that. Yeah, go ahead.
Now, treatment of the underlying cause. The underlying cause has to be treated along with the pharmacotherapy. The low anti-seizure drug levels in patients with known epilepsy have to be corrected. The medication list has to be reviewed. And if there are any potential causative drugs like antibiotics or any immunosuppressive agents which can precipitate seizures, they should be stopped. Any enzyme inducing drugs should be stopped. There should be treatment of underlying systemic conditions like infections, electrolyte imbalances, renal failure, hypertensive encephalopathy, hyperammonemia, hypoglycemia, etc. Surgical intervention should be done in cases of brain tumor or brain abscess, and there should be supportive medical strategies like steroids and autoimmune encephalitis. The likelihood of response to initial therapy is always good in absence status epilepticus or focal non-convulsive status epilepticus without impairment of consciousness. It is focal non-convulsive status epilepticus with impairment of consciousness may take time to get resolved, and repeated trial of multiple medications can be given. But non-convulsive status epilepticus in coma, it may be resistant to the initial therapy and the subsequent therapies. It may require additional treatment with intubation and coma-inducing drugs. Outcomes are usually good in ambulatory patients who have history of epilepsy, but acutely ill, stuporous, or comatose patients do have poor prognosis, and the prognosis may not just be related to the non-convulsive status epilepticus, but to the underlying condition as well. Coming to the take-home message, a high index of suspicion and a low threshold for considering NCSE has to be kept. There has to be awareness about diagnosing non-convulsive status epilepticus. After getting the CT done in a patient with altered sensorium, if the CT is absolutely normal, then we need to order an EEG at the earliest after sending the blood investigations ruling out any metabolic disorder. There should be appropriate identification of the population at risk, recognition of the possible subtle symptoms and signs, early and appropriate length of EEG monitoring. They are all paramount in the diagnosis and ultimate treatment of non-convulsive status epilepticus. Whether or not patients will benefit from treatment of certain EEG patterns, which are mostly seen in encephalopathies, that needs to be decided in adjunct with the clinical context. Maybe if there is a paradoxical improvement after giving any benzodiazepine or anti-seizure medication, then definitely the patient will benefit and we should consider it as non-convulsive status. Non-convulsive status epilepticus in the aftermath of convulsive status epilepticus or in acute brain injury, like cases of head injury, subarachnoid hemorrhage, or in ICH, has to be managed aggressively. Thank you. And I'm really sorry for all the goof ups, but my slides had a lot of animations. I'm sorry.
Thank you, ma'am. Thank you for that clear and comprehensive presentation on non-convulsive status epilepticus. So I think you still did a great job, ma'am, despite of all these problems with the slides. One question is there in the chat from Dr. Rohini. When to consider titrating the anesthetic drugs used as infusion for control of non-convulsive status? I think Madam is asking about hiking up or coming down once the anesthetic was administered.
In our institute, after we achieve a burst suppression for 24 hours, we start tapering it in with the continuous EEG on. But there are many studies nowadays. People don't even believe in inducing a burst suppression, even if there are no epileptiform discharges. The doses of those medication can be continued as same, but tapering has to be done after 24 to 48 hours only with the help of continuous EEG monitoring.
Madam, the last part where you had told that there are few subtypes of non-convulsive status where you need not be very aggressive.
Yes.
How are the outcomes, ma'am? Is it okay despite of not
They are
being
very good.
aggressive for?
In absence status epilepticus, it has an excellent outcome. They usually
Okay.
respond to valproate also.
Okay.
And in case a valproate, if they are not if they are already on valproate, then benzodiazepine can be given, and the status usually terminates quickly.
Okay. So patients with intact consciousness and absent seizures, they do pretty well without aggressive treatment, if I'm correct.
Yes,
Right, ma'am?
surely.
Yeah. So, ma'am, any concluding remarks which you want to give for our crowd?
Actually, we have to suspect. Matlab, a high index of suspicion has to be kept for non-convulsive status epilepticus. This is what I want to mention.
Can I ask
Yeah,
one question?
Yes, ma'am.
Yeah, please, ma'am, go ahead.
That's a very practical question. Like in LMIC, not even in LMIC. I think my voice is echoing. So, how many patients, how frequently you go for EEG monitoring of patients to detect non-convulsive status? Because putting non EEG for monitoring itself is a massive task, and
I mean, any patient of head
moreover,
injury.
I even then I feel like we have been doing EEG for traumatic brain injury just to see the incidence. So the effect of drug is very prominent in those patients. Like if patient is receiving midazolam, generally what you see is slowing all the time. So lots of data to interpret, lots of information to see. So it is very difficult. So do you think the role of QEEG with a compressed spectrum would be a better thing? And what do you think about the role of non-invasive EEG? Because limitation here is technicians which are required to put the EEG electrodes, they are limited. Neurologists who need to interpret pages and pages of EEG to find the diagnosis are limited. So, do you think there should be a technology, because we are quoting up to 35% incidence of status epilepticus, non-convulsive? So, what do you what way we should progress so that the EEG becomes a popular tool? Because right now everybody is little apprehensive when it comes to diagnosing, putting the EEG electrodes. Do you suggest a way forward?
Fortunately, the setup continues to be available. But obviously, if there are rapid ways and in which these EEGs with limited electrodes come into picture, then the chances of diagnosing non-convulsive status epilepticus in most of the setups will be quite high. And what I believe is that patients with head injury or patients who had previously generalized convulsive status epilepticus, they definitely need to be managed at the earliest. So if we have these modalities available, then the outcome in such patients whom even a single seizure can lead to increase in ICP and coning would definitely and surely help.
Right. So, I think, Dr. Bharat, there is one more question. The question seems same, that processed EEG or the QEEG in status epilepticus probably. So I think there is emerging role wherein
Yes,
alerts
yes,
can
yes.
be created for
Because
24 hours.
I
Right,
have not
please.
used it per se, but the studies I gone through for this presentation, they all say that the sensitivity and specificity as of now is less than the continuous EEG. So
So
we
what we do is like, if we I happen to see few of the pages, like 10-15 pages, like hours of monitoring for 24 hours. You compress the EG for 24 hours and you can create alerts. So those alerts, so I have seen, like, though the incidence which we could find in limited set of patients is not very high, but those alerts can help us to develop a robust system of monitoring. So maybe in future, when more
yes,
centers are using it
yes, yes,
and we
yes,
are more frequent with the use of QEEG monitoring and compressed
yes.
EEG or process, it will be helpful. And Dr. Swami is asking about processed EEG, or what, you have any take? Dr. Bharat, you want to say anything about it? Processed EEG.
I think we have discussed enough, ma'am, that there is definitely a role, but however, the clinical effectiveness still needs to be proven in terms of whether it is as
And for
good or not.
BIS and other monitors, probably they have their limited rules in application of detection of status, or that
Maybe
was
there
very
is a role
informative.
for AI for especially EEG processing to be early and reduce the burden on the physician and the neurologist. Maybe that
Right.
can be a future to look at for us.
I agree. I agree with both of you. And Dr. Sarika, very nice presentation.
I'm
Glitches
really
apart,
sorry for
it went very well. No, no, it went very well, and it can happen anytime. Thank you very much for so many questions and uh, participation. And Dr. Bharat can thank.
Yeah. I thank you, Dr. Sarika, for this presentation and for the interaction and answering all of our questions. And I'm sure the viewers also would appreciate your efforts. And I thank NCSI for this webinar and organizing it. And I think we have had a good learning session. Anything to say to the crowd, Dr. Sarika?
just that you have to keep a high index of suspicion for non-convulsive status epilepticus.
Yeah.
Only then you won't miss it.
Yeah. Thank you, ma'am.
Thank you so much.
Thank you,
And
everyone,
thank
for
you,
joining us
CSI,
online.
for giving me this opportunity. Thank you so much.
Thank you, ma'am.